Welcome back to the Lipoedema podcast. We are your host, Shell.
And tonight we are joined by a very special guest, the wonderful Sally Baker. Sally, thank you so much for joining us tonight.
Thank you so much for having me.
Now, we had the pleasure of meeting you in person at the Lipoedema Australia conference, and I wanted you to have the opportunity to sort of delve into all of your experience. We like to keep episodes to 30 minutes, but I dare say, being a Lipoedema warrior and a registered nurse and somebody who now works with Professor Cheyenne, that we have so much to talk about with you. So let's kick off. We're going to ask the question that we ask most of our warriors. How did you come to learn of lipedema, and when was that?
Yes, well, I always knew there was something not quite right with my body, and I was different to the rest of my family. I grew up in a really health-conscious household where being fat was the worst thing that anyone could ever possibly imagine. I saw something on TV in the late 1990s, so well into my 20s, late 20s, and I thought that it looked and sounded a lot like me. But when I brought it up with my family, I was told that I was just making excuses for being fat and lazy. So it wasn't until I'd been through a failed lap band in 2000 where I lost a total of 1 kilogram, and all my fault, of course. And then a revision to a gastric bypass in 2018 where I lost a whopping 100 kilograms and realized that my legs were still huge. And finally I decided that I did in fact have lipedema, and I went to see my absolute angel, Lucy Melican, who's a lipedema practitioner, a physiotherapist in Melbourne, who confirmed that I did indeed have lipedema, and all I can say is there were a lot of tears shed that day. So that's where I first came around to understanding that lipedema was a thing and that it wasn't my fault and that I had a disease, but it took a long time, and I was well into my 50s when that happened.
Wow, I can't imagine growing up in a household where it was, the body image thing was so prevalent for you, because growing up in a larger body and just feeling alienated in that space would have been really challenging.
Yes, it was. And I mean, even to the point where my auntie, I believe, had lipedema, and my grandmother, and at Christmas my dad would move the chairs that didn't have arms on them and laugh because, watch the relative try and find a chair to sit in. So it was really quite dysfunctional and quite cruel. There's a lot of trauma involved there, but this is not an unusual story at all.
Unfortunately, you're right. And I suppose the more we share these stories and how common they are, the better we can learn from them in the future.
100%.
So, when you got diagnosed, and that must, as you said, that really brought out a whole bunch of emotions. When you look back at your time with lipedema, now that you sort of know what it is once you've got a diagnosis, what was your experience through your life with it? When did it sort of occur first, and did it progress at any particular stage? Can you walk us through those timelines?
Yeah, well, I always knew that my body was different to the rest of the family, but I was quite like my grandma and my aunt. I know that at the age of 5, my mum put me on a very restricted diet because of my allergies. I have no idea what those allergies were. I think they were made up. I was then on diets for the rest of my childhood. Mum really ramped it up at around the age of 9 when I wasn't allowed to eat any carbs at all. And I remember hearing my mum say at a birthday party that I went to, that she told the host that I wasn't allowed to eat anything, and if I did, could she please write it down and let my mum know what I'd eaten at that party. I knew my granny had bad legs, but I never knew why. I do now. And interestingly, those two family members were the longest living family members in our extended family. And my granny lived until she was 100. And the only health issue she had was that she had painful legs. But really, you know, lipedema shaped the course of my life. I was bullied at school, treated badly by my family. Thankfully, I met a man who loved me for me, and we've been married for 35 something years. We had issues with fertility. We were refused IVF because of my weight. We were nearly barred from intercountry adoption due to my weight issues. We ended up adopting 2 special needs children from overseas, one who interestingly has a lymphatic malformation of her arm, so I'm well equipped to help her. And I gave up nursing because of the pain in my legs. I couldn't stand for 8 to 10 hour shifts in a busy acute care ward. So finally finding out that I had lipedema and then having surgery with Ramin basically changed the entire course of my life. And I honestly can't thank that man enough for A, giving me a new career, and B, giving me my legs back and enabling me to walk and be without pain. Now that I've completed the surgical side of my management, having had 8 litres of lipedema fat removed from each of my legs after 100 kilogram weight loss, and having my arms, tummy, boobs and bum all done by Ramin, then, you know, I feel like I've kind of come out the other side and now I'm ready to give back. Ramin's technique of large volume liposuction and the additional skin removal has really provided me with the best outcome I could possibly have imagined. And I think that if you look at my before and after photos, you can see that I've had a dramatic transformation and that most people can't even possibly believe the outcome that I've had, really. It's quite incredible, which is probably why Ramin uses a lot of my photos in his talks constantly. See my legs on the screen.
You're famous. Your legs are famous.
The legs are famous, yeah.
And do you share that on your own? Like, how can our audience access those photos? Is there any way that they can look at those photos?
Oh, yes, I have them on my lipedema page, on my Instagram page. So that's the lipedema.
I'll make sure I put that in the show notes.
Yeah.
Oh, perfect. Thank you. So I just wanted to, while we were there, wanted to make sure I covered that. Beautiful.
I'm so sorry, ladies. My daughter has decided to come and join. Shell, I'm going to let you just continue on with the questions while I do some parenting.
Do some mommying. No worries. All right. So, yes, so you've had your surgery, and yes, I can't wait to look at the photos myself, and I will put it in the show notes how anyone can find the photos. So you said that now it's conservative management. So what are your steps that you take in managing your lipedema now?
Yeah, so for me, the goal is now to maintain the status quo. Menopause wasn't particularly kind, but I did manage to keep it under control. I practice conservative management every day. And the key, and this is what I talk about with my patients as well, the key is always reducing inflammation and fibrosis. I wear compression every single day, even though I'm post-op, every day. I wear comfy wave every night because that's what I find keeps my legs soft, and I find that I have less regrowth. And despite all the things that people will tell you, regrowth is a possibility after surgery. Surgery is not the end goal, and hormonal change and inflammation will cause regrowth to occur no matter how much effort you put in, and we really can't be beating ourselves up about that. I exercise regularly, so using my muscle pump in my legs with my compression to keep my lymphatic vessels working, and I work on building strong legs so that I can stay mobile as long as possible as I age. But for me, that is all. So, so reducing
Okay.
the inflammation and the fibrosis is always the key for me.
Yeah, yeah, that makes a lot of sense. I love how you said that you strengthening your muscles. I feel like that's such a key. And you're using compression. Can you talk us through your compression wear?
Yeah, so I basically wear either Bioflex during the day or Sigvaris thigh highs, depending on what I want to wear them under. And I use the Comfy Wave at night, for the full length Comfy Wave for the nighttime on both my legs. I do have lymphedema, quite significant lymphedema in my left leg, so I do have to be very careful about that. And I don't think people necessarily understand the problem with lymphedema, in that people will talk about just having swelling. But the problem with lymphedema is that the high protein fluid that lymphedema is, which, Remin believes that most women with lipedema have some degree of lymphedema as well, that that high protein fluid causes inflammation. That inflammation causes fibrosis. Then once we have fibrosis creates or attracts adipocytes or fat cells to the area, so you get fat deposition as well. So you've got this vicious circle. What does the fat deposition do? It creates more inflammation. So you've got this circle of inflammation, fibrosis, and fat deposition in lymphedema, which of course is very similar to what we're trying to avoid with lipedema, that fat deposition. So controlling your lymphedema is just as important as controlling the lipedema aspect of things. And I believe that in most women with lipedema that there is some component of lymphedema present as well.
Yeah, and I suppose that's where all of the lymphatic therapies come in really handy, because that's what they're targeting, like the lymph system and the lymphatic fluid and the exiting of all of that waste product, I suppose.
Yeah, well, we're trying to protect our lymphatic system and keep those channels flowing, because the lipedema is pressing on them and creating blockages and requiring fluid to go around a different way. So we have to protect that as best we can.
Yeah, fantastic. So, Sally, you're an experienced registered nurse with over 35 years of experience, and your personal journey, which you've just spoken about, has driven you to return to nursing to support the lipedema community, which I think is just amazing. Can you talk us about this new journey for you and your role with Dr. or Professor Cheyenne?
Yeah, so it really came about. So as I was having my treatments and surgery with Ramin, I started talking to him about how we could support women better through the surgical process to have improved outcomes. And Ramin was really keen to build a multidisciplinary team, and he asked if I would come on board. But at the time, I didn't have my nursing registration. I had been out too long, so I'd lost it because I was caring for my high-need children. So he said to me that, go back and get my registration and then, come back on board. Little did I know at the time it was going to take me 2 years full time to go back and do my entire degree again from scratch. So here we are 2 years later and registered again. And then Ramin and I decided that I would be of more value if I trained as a lymphedema practitioner as well and had that extra layer of knowledge. And I completed that earlier this year. So now an Australasian Lymphology Association accredited lymphedema practitioner. So my role with Ramin is really to assess each new referral that has either lymphedema or lipedema and to provide support and education while they prepare for surgical management. And Ramin does provide surgical management of lymphedema as well as lipedema. I'm currently building a network of lipedema-aware health professionals around Australia who can help me prepare patients for lipedema surgery. And so having both the nursing and lymphedema qualification as well as the lived experience really gives me the opportunity to provide expert evidence-based care and education. And I honestly believe that it's not something that's being done elsewhere. I don't know of anyone else in a role similar to this anywhere in the world, really. So it's really, really exciting. It's a lot of work. It's taking me a little while to get my head around what's important and what's not. The conference was really helpful because it helped me to base my assessments in research, and especially the talks by Karen Herbst really helped me to identify what sorts of things I should be looking for in terms of hypermobility, mast cell activation syndrome, ADHD, all of those things. And so, yes, it's just been a matter of working out where the missing information is and how we can best support women along the process to surgery, because it's quite a long process.
Yeah,
And so,
absolutely.
Sally, sorry, does Professor Cheyenne, does he diagnose as well, or women come to you already diagnosed and are just come to you for surgery?
Yeah. Great question. So I don't believe it's appropriate for people to wait 18 months for a consult with Ramin to get a diagnosis. There is so much that they can be doing in that time while they're waiting. If they have to wait 18 months to talk to him to get a diagnosis, that's too long. So one of my first things that I do, I can diagnose, but it's a little bit difficult as a nurse. There's a little bit of a crossover where nurses aren't supposed to diagnose. However, I will send them to, my first thing I do is make sure they have a lymphedema practitioner in their toolbox that they can go and get a diagnosis from first. So then they can come back to me and then we can move on.
Yeah, awesome.
Yeah, that's brilliant. Because you're so right. Having a feeling that you have lipedema and then finding someone like, Professor Cheyenne that could diagnose you and then knowing you have to wait 18 months. I don't know if I could have done that, if I could have waited that long. So that's really good approach to find a lymphedema specialist.
It's a bit of a waste of time too. You could be doing so much in that time. And then if you've got someone who doesn't actually have lipedema, because believe me, we're getting a lot who don't because they've seen something on TikTok and suddenly they think they have lipedema, which I completely understand. However, their treatment is not, we don't need to go down the path of lipedema surgery with those particular women. So they need to know up front whether they have it or not. They don't want to wait 18 months to be told that.
Yeah, that's so true. And that's so interesting that you say that, because I feel like the message that we're hearing as the warriors is that it's everywhere and there's more and more women getting diagnosed and more people, which is a great thing. But then, from the community, from the medical community, is it like, well, is there obesity without lipedema? And you're saying that there absolutely is.
100% there is, and I belong to a lot of the bariatric support groups on Facebook, and there's a lot of women there with lipedema who don't know they have it, but then there's an enormous number who clearly don't have it either. And I think people get it's when you see it so often, you can pick it straight away. So, however, in the earlier stages, it is much more difficult to identify whether it's there or not. So you need an expert to be looking at that.
Yeah,
I think we've got to remember that not everybody who has a curvy backside and a small waist has lipedema. Not everybody with thick thighs has lipedema. Like it is such a complex condition, disease, syndrome, as Karen said, that it's not just these one things. And just recently, and I was going to post about it, there's like 4 main women that I follow that live in larger bodies. 2 of them, or all 4 of them, were asked if they had thought of lipedema. 2 got diagnosed and 1 has undergone surgery, and the other 2 just said, no, I've just got cellulite, man, and so even though we're getting the word out there, we can't just say, oh, you must have that. Because there are so many complexities, and someone in your situation is a lot more educated to make the call than someone who just saw it on TikTok.
100%. Yeah.
So I'm really curious to hear, Sally, with all of your experience as a registered nurse and then with your, extensive personal experience with lipedema, was there anything that surprised you when you got your lymphatic education that you hadn't thought about, or something that you think the community should know, or something that makes sense to you about the lymphatic system?
I think it was what I said before about the process of, I didn't understand with lymphedema that process is very similar, of the inflammation, fibrosis, fat deposition, and that there is so much crossover between the two. Yes, they are distinct entities, and that they have, one's fluid, one's fat, but there is a lot of crossover. And the role of the lymphedema practitioner, they're the person that is best equipped to manage that, both lymphedema and lipedema. So I was quite surprised in the course that there was a lot of content on lipedema, and that was really encouraging, because it means that the people who are now training as lymphedema practitioners are very aware of lipedema. Some of the ones who've done training many, many years ago may not be as familiar with it, but I was surprised at the level of knowledge. And I also, I think there's always a lot of discussion about whether we need to be wearing compression or not. And I think that what I learned is that, yes, we do need to wear compression. And I think that was backed up by Karen Herbst in her talks at the Lipoedema Australia conference, where she talked about all the reasons why we should be wearing compression. And the standout comment that she made, which blew me away because I had not thought about it, is that the pressure on the fat from the compression tells the fat to stop growing. Is that not enough reason to be wearing compression?
Mate, sign me up.
It's giving it a signal to say, you've grown enough, you don't need to grow anymore.
Fascinating. Yeah, I remember that now. The other thing about lymphedema and lipedema, I suppose, because we're talking about fluid in the body, and when I was diet focused and being skinny focused in my younger life, and I knew that I sort of was puffy with water weight, and I didn't realize what lymphedema or lipedema was. I was like, well, if I took anti-inflammatories and or diuretics, I drop weight really quickly. Now I can understand why that's not healthy, but can you talk a little bit about why that's definitely not the answer?
Yeah. Okay. So diuretics used inappropriately, what we have to understand that lymphedema fluid, that even if it's associated with lipedema or lymphedema, is protein rich. So when we take diuretics, all we're doing is pulling the water content out of that and leaving the protein behind. So yes, you will drop water weight, but what are you leaving behind? The protein. And what does the protein do? It causes inflammation, fibrosis, fat deposition, that same cycle again. So the more you take diuretics, of course, if you have kidney disease, liver disease, or heart disease, it may be warranted. But the fluid from those conditions are not protein rich. They have a lesser amount of protein in them. So taking the fluid out of that is beneficial. Taking the fluid out of the protein-rich lymphedema fluid leaves the protein and causes inflammation and makes the condition worse.
Thank you for explaining that, because I'm sure my 20-year-old self isn't alone in thinking that, being obsessed with being smaller and that's just like a really quick fix. And it's really nice to have like an explanation as to it's doing more harm than good in the plight of being smaller.
And it's one of my biggest frustrations.
Sorry, go.
It's one of my biggest frustrations that we get a lot of new referrals and the GP has put them on a diuretic without even thinking about what the implications of that are. And the patient is taking that religiously because they've been told by the GP to do that. And it's so contraindicated. It's dangerous and it's causing so many more problems. And it's really sad to think that women are, and this is women who have lipedema but have been incorrectly diagnosed by their GP with lymphedema, but are still being given the incorrect treatment for lymphedema, even though they've been diagnosed with a condition that they don't necessarily have. They have lipedema instead, but then even being given the wrong treatment for the thing they were diagnosed with. It blows my mind.
It's so challenging. Yeah. Wow.
And I guess if you're taking the diuretic, the lymphatic fluid is full of toxins. Like, its job is to get toxins out of the body. So if you're just stripping that fluid, where are the toxins going?
Correct. They're staying exactly
that's a
there
great
and
point
causing
too.
more inflammation. Yeah.
They're staying there and
Yikes.
Oh, that's scary stuff.
So I'm curious, what about things like Duramine, which sort of do a couple of different things? Like, they target the lifestyle fat, but they also like massive diuretic. Both Shell and I have had experience with Duramine, and apart from making you feel absolutely horrendous and high as a kite, the diuretic and then the fat,
I mean, Duramine's just really a legalized speed, really. All it's doing is speeding up your metabolism. So it's not a long-term solution. Yes, you might lose a little bit of lifestyle fat on it, but lifestyle weight, but it's really not ideal. The game changer is going to be Ozempic and Mounjaro, the GLP-1 agonists. I'm collecting some stats at the moment, so I'm just looking at how many women are actually with lipedema are actually on these medications, and there's a lot. And the majority of women, even if they are not losing weight on these medications, they are finding decreased symptoms of pain and heaviness in their legs. So is that going to be enough to say that it's a worthwhile thing to do? Potentially yes, but it needs a lot more investigation. And then, on top of that, you've got the whole weight loss surgery debate. And in my opinion, I think that, lap band does nothing because there's no hormonal change. Sleeve has a moderate effect. Bypass, yes, can be very effective, which is what I've had, bypass, R&Y bypass, because RNY bypass causes a hormonal change, so it changes the insulin production. And we know in lipedema that that insulin resistance is a big problem. So getting that under control is, I think, why I had such a good result with the RNY bypass, whereas I didn't lose anything with the gastric band. But long term, it's still up to me to do the management side of things.
Yeah.
I'm so glad you said that.
Yeah.
It's so important.
And it's very individual too, isn't it? Like what works for one person might not work for the majority. You know,
100%.
we are bringing in these, because we're all multifaceted. We're not just this one thing. We're not just lipedema. And we've got so many different comorbidities and yeah.
And it's interesting, the whole issue of the mast cell activation syndrome. I can't wait to see more research on that because I have mast cell activation syndrome very clearly, never been linked to lipedema, but when I had a massive flare about 20 years ago, I was basically covered head to toe in hives for 6 months. We didn't know what was causing it. And so I was on a diet of steak, potatoes, and pears. That was the only 3 things I was allowed to eat. And they said, you're going to lose so much weight on this because you're not allowed to eat anything. And I gained 20 kilos. So when Karen Herbst stood there and said mast cell activation syndrome is a driver of lipedema growth, I just went, okay. That was why I gained 20 kilos, not lost 20 kilos when I wasn't eating anything.
Because it was lipedema fat, it wasn't lifestyle.
Correct.
Yeah.
So much to unpack.
So much. All right, you did speak before, Sally. We started talking about what a lymphedema practitioner does. Can you tell us what they do in managing lipedema? Like, what's their role?
Yeah, so really lymphedema practitioners are best served to provide care for women with lipedema because of their in-depth knowledge of the lymphatic system, and that's so vital. And the treatment options have a large crossover. So as I said before, despite the view of a lot of people that lymphedema and lipedema are completely separate and there's no crossover, there are researchers who believe that, and Ramin believes that there is lymphedema present in many women who have lipedema. And personally for me, that's definitely true. And, you know, my legs look pretty normal now, but I've still got lymphedema in them. The key to, as we said, the key to managing lipedema is reducing the inflammation and fibrosis. You do that through MLD, manual lymphatic drainage massage, prescribing appropriate compression, the use of pumps, low-level laser to reduce inflammation, and, of course, education. And really the only health professionals that have those skills are lymphedema practitioners. And a lot of even the going for the treatments is not necessarily about the treatment. It's about the education and support you get while you're at the treatment, if that makes sense.
Yeah. And that's an ALA registered.
Yeah, so I would always choose an Australasian Lymphology Association accredited lymphedema practitioner, and you can search for them on the ALA Find a Practitioner website, and you just put in your location. It will come up with
link in
the accredited people in your area. Not everybody that's accredited is on that list. I'm not, and the only reason I'm not on that list is because I don't need extra patients. I've got enough.
They don't need to fund you.
Yeah.
Awesome. That is awesome, Sally. All right. So what we sort of touched on it a little bit, but what are the first steps when you meet someone who's been newly diagnosed and is interested in surgery?
Yeah. So
What do
first
you
thing,
walk through with them?
yeah, so first thing is we set up I call it an intake assessment. So I just do that by phone because I find that's easier to get people to talk. And we have a lot of interstate patients, so and overseas patients, so it's easier to do it that way. I take a history, I ask about their experience of lipedema throughout their life, triggers, symptoms, their social situation, and I have to emphasize the social situation because I come across so many women who are so desperate for help with their lipedema that they are preferencing getting surgery for their lipedema above having a roof over their head. So we have women who are homeless that want surgery for their lipedema that's going to cost many thousands of dollars, and it breaks my heart. So I have to know that you have stable housing and you're in a stable, you're not in an environment of domestic violence or, struggling with trauma or other things so that you can proceed safely to surgery. And then I ensure that they're connected with a team of people to help them, like I said, with the lymphedema practitioner, and that's an absolute must. They must have a lymphedema practitioner, nutritionist, GP, psychologist, exercise physiologist, depending on the individual's needs and where they're at. Some people come to me extremely prepared, and other people have not thought about a single thing. They just want surgery straight away. So sometimes I'm talking people down about being prepared and getting ready rather than needing surgery tomorrow. We talk about goals and expectations, and I go through Rumin's surgical procedure, the whys and hows, and I answer all their questions. Usually there's a lot. We do talk about weight, but we talk about it in terms of waist to height ratios and waist to hip ratios and how to optimize those for the best surgical outcomes. And one of the reason we talk about weight is not because of the number on the scale. It's because of the inflammation and fibrosis. So this is one of my biggest jobs, is talking about how to optimize weight to reduce inflammation and fibrosis to make it easier for Rumin to get it out. So an example of that I often give is that if I went into surgery when I did and I had lost 100 kilos and a friend of mine went in and had surgery at the same time and had not lost any weight because she didn't need to, we were the same weight, my result is much better than hers, because my tissue was softer and less fibrotic. It was easier to get out because I'd lost weight, because fat is inflammatory, fat is fibrotic, or it causes fibrosis, I should say, because of the inflammation. So if that weight is coming down, then you're going to have less inflammation and less fibrosis. That makes it, fibrotic tissue doesn't just come up a liposuction cannula. It has to be broken up first to come out. So the softer that tissue is, the easier it is to get out and the better result you're going to get. So I'm trying to help people help themselves almost. It's really hard to talk about weight to women with lipedema, which is one of the bonuses of having me, because I've done it myself. I am one of the family, I guess. But it's important that people understand they do have power in this and that they can make changes in order to get the best result they can. And the last thing Rumin or I want is for people to be disappointed with their surgical result after paying so much money and going through so much trauma and exerting so much effort and time into getting the result and then being disappointed with the outcome. So not about the number on the scale.
Yeah, absolutely. And and it was, I think it was through all these conversations that I finally realized, because I got told my BMI was too high and that I had to lose weight. But the reasons behind it, so now I know the reasons behind it, because if I go into surgery now, there's only a certain amount of time I can be on that table.
Correct.
So my tissue has to be as soft and as pliable as possible so that the whole time I am on that table, it's just getting rid of that diseased tissue. Otherwise, like, I'm not going to get the results I want.
100%.
But yeah, and I think with you explaining that, you're explaining that, so you're educating at the same time, and we need more of that instead of just like, no, it's BMI. Well, no, it's not BMI. It's because we want the best results possible for the amount of time we've got.
Yeah. And if you think about it, what comes up the liposuction cannula easily? Lifestyle fat. What doesn't come up the liposuction cannula easily? Fibrotic fat. Lipedema fat doesn't. So the softer that tissue is, the easier it is to get out. And that's what we have to focus on. I always talk about it's not the number on the scale. So we look at, if you do a waist to height ratio, if it's greater than 0.5, that will probably indicate that you have lifestyle weight to lose. So half your height should be your waist measurement or below. So if it's above that, you probably have some lifestyle weight there that can be lost. But even in saying that, weight loss reduces inflammation. So all of those things you can do to reduce your inflammation means that you're going to have less fibrosis and it's easier for it to come out. So it's a combination of things that has to occur. It's not just about the weight loss.
Yeah. And it's also doing it the right way too, making sure
Correct.
we're nourishing ourselves enough. And yeah, it's so complex.
Yeah, and you're not gonna have good wound healing if you haven't got correct nourishment. If your protein intake and your muscle and collagen and skin and all of those things, hydration even, are not on par, then you're not going to heal very well.
Yeah,
No,
that's right.
such an important message. Yeah, eat that protein, ladies.
Eat
those veggies. Eat the protein.
Protein.
Awesome. Oh, Sally, we've had such a great time talking to you. Before we wrap up with you, we're keen to know what's exciting coming up for the rest of 2024.
Well, at the moment, it's about me continuing to build this role and working out how the best way to help our patients is. And I'm, getting feedback about that and looking at ways we can improve things, because the wait for consult is still very long, but we're hoping to get that down a bit as well. But also I'm hoping that we can, I personally can publish some articles. I've already done some work in Nursing Journal. There was an article published. So when you think that goes to every nurse in Australia, and the headline was, lipedema, that's great publicity for us. And working with the bariatric support pages to try and educate there as well, and then trying to put out appropriate, relevant and evidence-based information on my Instagram page as well, because as we know, there's a lot of misinformation out there, so trying to keep it real. I'm really outside my comfort zone, but I'm learning, learning. So yes, just trying to find my way still.
Oh, good on you, Sally. And what's your Instagram account for our listeners, please?
It's just one word, the Lipoedema Support Nurse.
Amazing. Go follow the Lipoedema Support Nurse, everyone. Sally, you're an absolute gift to the Lipoedema community. Ramin has put together such an amazing multidisciplinary team, of which you are such an asset. Thank you so much for coming on tonight. We hope to have you back on next year for an update with us, and can't wait to see more of your work being published.
Thank you so much for having me.
Thank you, Sally.
Thanks.
Bye.
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 started the Lipoedema podcast, we relied on word of mouth and existing connections.
Our following has happened organically, and we are so honoured by your support.
As we learn more about the world of social media and algorithms, we have a request.
When you are listening to our podcast or watching on YouTube, let us know what you think.
Hit follow or subscribe.
Leave us a comment or write a review.
The more engagement we get, the more our message is shared.
And the greater our reach to those women suffering in silence.
Thank you for listening to the Lipoedema podcast. Lipedema and its symptoms vary from individual to individual. The opinions and advice voiced in this podcast are of a personal nature and used for educational purposes.
Please take away from this podcast what resonates with you, and please see your GP or preferred specialist for diagnosis and healthcare. We are Shelley and Tiana from the Lipoedema podcast. Until our next episode, bye for now.